defective. I'm not repeating that entire table, the family, the carrier, all of that we know. We know this was also one of the most common causes of fulminant hepatitis, right? We already know. I'm going to tell you something extra. There is something called a co-infection and a super-infection. So this is kind of understood. Co-infection matlab saath-saath. B and D are going to occur together. Super infection will mean one on top of the other. So remember, if hepatitis B and D infection occurs together, that is known as co-infection, and this is usually going to clear off. But which scenario is it going to be very deadly? In case of IV drug abusers. So this is something which you very commonly also see in IV drug abusers, and over there it is going to be resulting in a co-infection. So that is when I will say it can result in fulminancy. That is when I can say it can result in fulminancy. Otherwise, I'm saying it is not the one that is going to result in fulminancy. It can clear off quite easily. But in IV drug abusers, it can cause fulminancy. Whereas what is a super infection? The person already had HBV, B was there, and super on top of it, he got infected with HDV. So basically, HDV has done a rule, hepatitis D, that HBV should be there. Either I will go with HBV, or wherever HBV is sitting, I will go and sit over there. So I will go as co-infection, or I will go as super infection. Yes, super infection causes fulminancy, but co-infection can cause fulminancy in which scenario? In IV drug abusers. So this is the most common cause of fulminant hepatitis. But fulminant hepatitis in pregnancy, I have told you, is caused by hepatitis E. Okay, so this was about hepatitis D. Again, nothing much known. We all know it is non-cultivable. We all know that table, so that remains as it is. Now we move on to the last one, and that is going to be hepatitis C. What is it about it? It is one of the mutable viruses. That is why. Now I'm going to tell you something. Highly mutable virus. It is constantly mutating. So how should I make a vaccine against it? Ma'am, by the time I pick up one strain and I make a vaccine against it, it has already mutated and another strain has come out. So how should I make a vaccine? The most mutable protein out of them is going to be E2. So remember, highly mutable, most mutable is E2, and this is not going to help in vaccine production, and that is going to be known as quasi-species. What is quasi-species? I always used to joke about this on my Telegram group. I still do. You must have seen on Telegram there are a lot of students who are constantly trying to promote some codes and some app codes that are there. So there are Autobot settings on the group which tends to ban anyone who's trying to illegally sell or purchase these accounts. So by the time the group used to delete one of them, they used to come up with a new username and come up with a new account. Then the group used to delete them. Then again they used to come up with a new username and a new account. So that I always used to say, these are quasi-species. These people are quasi-species, that by the time you decide that I will make antibodies against this virus, that virus has only changed. The next strain comes, you say, okay, by the time I will make antibodies against it, again the virus has changed, and that is quasi-species. So it doesn't have a definition, but this Telegram user thing which I have told you, which all of you have seen, will definitely be relatable, right? That is known as quasi-species. How does it spread? Very important. One of the most important spreads are parenteral. Parenteral means IV drug abuse as well as blood transfusions. Parenteral route is very common. How do you do the lab diagnosis? Look at the virus, look at the antibody, nothing fancy about it. So which antibody am I talking about? IgM type of antibody. There is a card testing. We all know hepatitis B ka, C ka, sabka ek card testing hota hai. So for this there is an HBC tridot, which is nothing but HCV tridot, which is nothing but a kind of a card testing which you have. And finally, the diagnosis of choice will always be the HCV RNA. Nothing can beat that. So this is not drug of choice, this is diagnosis of choice. Diagnosis of choice will always be measuring the RNA PCR directly, but yeah, in the absence, you can do antibody testing. Okay, all of this is done. Now, micro part is over. Nothing more in micro. Patho part comes now. What is it that you will see under the microscope? Firstly, you will say, why are you seeing something under the microscope, ma'am? Should you be seeing acute and chronic hepatitis under the microscope? Ideally, no. But still, I'm going to tell you. Okay? So, what are you going to see? In case of acute hepatitis, I think everyone is already aware that there are some bodies that you see in acute hepatitis, and those are known as the Councilman bodies, especially with which hepatitis? The starting stage of hepatitis C. Okay, so these are the Councilman bodies. You have seen this before in pathology also. Councilman bodies are nothing but the apoptotic bodies. And how are they going to look like? What are the three features of apoptotic bodies that you have? chota cell. There is cellular shrinkage that you see, and when you look at the cytoplasm, there is very, very pink cytoplasm, and if you look at the nucleus, there is a very, very blue nucleus that you will find. Let us label it. Look at the cell. Look at the cell. Look at any normal cell. Pehle ma'am, let's look at this is a hepatocyte. It's pretty big. If I compare this councilman body, what has happened to the size? The size has become chota. Look at the color of the cytoplasm, very, very pink. Compare karo, very, very pink. Look at the color of the nucleus. The nucleus has also become very, very blue. So every color is becoming more of pink, more of blue, and the size is becoming less. That is an apoptotic body known as councilman body. Other than that, damage to shuru ho gaya. Damage has started. So there is spotty and dropout necrosis. Little hepatocytes have started, getting necrosed. So spotty necrosis, and necrotic cells will ultimately die out. So that will be known as dropout necrosis. So spotty and dropout necrosis are seen. So now there are apoptotic bodies being formed, necrotic bodies being formed. So much of death happening. Who is the cell which is suddenly going to say, oh wow, so much of food, let me go and eat it? Macrophage. What is macrophage in the liver known as? Kupffer cell hyperplasia. So what are the findings? Councilman bodies, lot of spotty and dropout necrosis, and the macrophage has got a feast of food around it. So Kupffer cell hyperplasia, nothing but macrophages. Whereas what happens, this was all acute hepatitis. Acute hepatitis mein ek aur cheez batao that I've taught you. Acute hepatitis also has which two main feco-oral wala? Hepatitis A and hepatitis E. I think I've already told you that hepatitis A is going to show you an increase in the plasma cells, and hepatitis B is going to show you cholestasis or bile plugging, right? This we've already studied. Now let's come to something converting into chronic hepatitis. Chronic hepatitis ka matlab there is going to be fibrosis. Which is the most fibrogenic cytokine? Fibrogenic cytokine is always TGF-beta. Which cell of the liver releases this fibrotic mediators? Ito cells. Ito cells ka dusra naam? Stellate cells. So actually, it's the stellate cells which release these mediators. And where are stellate cells present? They are present in the space of Deci. If you are aware of all of this, very good. If you say, ma'am, I don't know what you're talking about, Ito, stellate, space of Deci, these are Greek words to me. Pick up the liver chapter. Maybe you've not read pathology as of now. Pick up the liver chapter. If it's not in your agenda, never mind. Listen to the first 7 minutes of that chapter. Bus. Because over there, all the normal of liver is discussed. After that, you can read it whenever you want to. But the first 7 to 8 minutes of that chapter is enough for you to understand. So there's a space called space of Deci. In that space, normally we have these cells called Ito or stellate cells. Stellate cells release these mediators called TGF-beta. TGF-beta, in pathology I've taught you, बहुत fibrosis. TGF-beta causes बहुत fibrosis. That is going to result in fibrosis, and that will result in chronic hepatitis. So which were the two ones which were main ones for chronic hepatitis? Hepatitis B, hepatitis C. So alag se pad lete hain na. When I'm saying chronic hepatitis, primarily I'm saying hepatitis B and hepatitis C. So let me look at them under the microscope. Hepatitis B, remember it had an antigen called HBsAg, Australia antigen, yes? So first you'll say, ma'am, pehle to tell me, can you look at it on a pink and blue slide and find out that maybe HBs antigen is there? Yes. We see ground glass hepatocytes. Can you all see there are these big cells which are diffusely pink? Ground glass hepatocytes are extremely pink cells, and they are indicative of hepatitis B surface antigen being present. I say, you say, ma'am, I don't trust you. Everything looks pink. Ab ye bhi pink hai. Prove it. Pathology mein to sab kuch pink hai. What is the pink stain? What is the stain that you can use? We have something called the Orsin-Shikata stain. Positivity. Hepatitis B surface antigen is Orsin-Shikata stain. Positivity. Very important. That is what you have for hepatitis B, ground glass hepatocytes. What do you have for hepatitis C? You have fatty liver and lots of lymphocytes. Fatty liver and lots of lymphocytes. Fatty liver kaunsa wala? Not chota wala. Fatty liver, big vesicles. Have a look at this picture. This is a picture of hepatitis C. Can you see big white spaces? Okay, ma'am, there is fatty liver. That too big vesicles. Macrovesicular steatosis or fatty liver is seen. And I can see some blue aggregates. This means I see the presence of lymphoid follicles. That is indicative of hepatitis C. So you will also ask me, कि big fat दिखा तो hepatitis C. But ma'am, you had taught us also that chota fat dikha to little fat is seen. So that little wala, that is hepatitis D. Now I want to tell you that hepatitis D is sab kuch little. Why do I say sab kuch little? Because I will remind you. Do you remember reading general virology and I asked you who has the smallest genome? The smallest genome was of this poor hepatitis D. Tabhi to khud se he can't do anything. He's always relying on hepatitis B. He has the smallest genome. Now I need to know that the same hepatitis D, which hepatitis shows you microvesicular fatty liver, osteotosis, also hepatitis D. So bichara chota sa genome, chota fat, and that is what is going to be hepatitis D. Let's do a recap. When I'm saying chronic hepatitis B shows you ground glass hepatocytes, hepatitis C shows you big fat and big lymphoid, hepatitis D shows you chota genome and chota fat. So you will say, ma'am, so much information of patho you've told us, full integration done. But the first line you said was कि biopsy करना ही नहीं है. You don't have to do a biopsy in a liver hepatitis case. Sometimes you have to. What is the indication of biopsy of the liver? Not in acute, but in chronic hepatitis for staging and grading. Please remember, in chronic hepatitis, when you have to do grading and staging of the hepatitis, that is when you do liver biopsy. So what are the features? Staging is based on how much of fibrosis has occurred, and grading is based on how much of inflammation and necrosis has occurred. कैसे याद करें? एक side, learn one side. Grading is based on inflammation and necrosis. So this is a word that everyone will remember, right? So when we say GIN, please remember grading is based on inflammation and necrosis, and then staging automatically becomes based on fibrosis. This is the indication of a liver biopsy in hepatitis. Otherwise, there is no indication. Okay. Now I had promised you, hepatitis done. I had promised you that right in the end, we will make one full table where we will study all of these. Yes, remember this? Let us start. If I ask you, which is the acute? देखो, acute hepatitis, you said, ma'am, या तो hepatitis A है या E है. So the most common cause of sporadic acute hepatitis in India is actually hepatitis E, Harrison. The most common cause of sporadic acute hepatitis in India, hepatitis E. Now let's come to the hepatitis which is fulminant, and I've taught you. If I would have just asked you fulminant, danger, so ma'am, सब कुछ तो छोटा था about it. Small genome, small fatty liver, microvesicular, but छोटा packet and बड़ा धमाका. It is gonna cause fulminant viral hepatitis, that is hepatitis D. But if I convert it into fulminant viral hepatitis in pregnancy, now I know that is going to be hepatitis E. So ये वाला part तो I already knew. Now let's move forward. Which is the most common transfusion related hepatitis? So blood transfusion से hepatitis B also happens and C also happens. But if I look at the prevalence wise more, hepatitis B is more prevalent. So transfusion related, it is going to be hepatitis B. Similarly, if I ask you chronic hepatitis, most common cause of chronic hepatitis, you will say, ma'am, going by prevalence, if you ask me most common cause, hepatitis B is always more common. But who has a greater potential of chronicity? There's a difference. See, most common cause is based on the number of cases and the prevalence. The most common cause of chronic hepatitis is hepatitis B. But who has a greater risk of converting to chronicity? That is going to be hepatitis C. Also, what is the most common cause of carrier state? Hepatitis B. What is the most common cause of hepatocellular carcinoma? Hepatitis B. But if I suddenly say which has the strongest association with hepatocellular carcinoma, that is hepatitis C. So overall, the easier way of learning this table is, देखो यहाँ तक तो table वैसे ही याद था. Acute hepatitis, hepatitis C, fulminant, hepatitis D, but fulminant in pregnancy, hepatitis E. Till here the table was simple. Now whenever someone asks you most common cause of transfusion related, most common cause of chronic hepatitis, most common cause of carrier state, most common cause of viral induced cancer, sabka answer is hepatitis B, because hepatitis B somewhere in prevalence is only more. But if I now ask you the maximum risk and potential of chronicity, the maximum risk and potential of chronicity is HCV, and the strongest association with hepatocellular carcinoma, HCV. Everyone's understood how to simplify this table? Good. Finally, the last table is other than hepatic, what are the extra hepatic manifestations that especially hepatitis B and hepatitis C have taught you in medicine, in path, in micro, everywhere. This is an integrated class, right? You must have heard in pathology, I taught you polyarthritis nodosa, the blood vessel problem, that is HbsAg positive in 30% cases. Padha hai? In kidney, I have taught you membranoglomerulonephropathy. Membranous glomerulonephropathy also is hepatitis B, also is hepatitis C. ये B and C दोनों के साथ है. Hepatitis C में the most common finding that you have to know is mixed cryoglobulinemia, very famous. In kidney, they ask you MPGN, and skin में you know lichen planus is associated with hepatitis C. Let me ask you one question from dermatology. Lichen planus shows you which bodies? Yes, which bodies? Colloid bodies. Colloid bodies C से होता है, hepatitis C वाला है. So lichen planus is colloid bodies and associated with hepatitis C. Finally, MPGN is also there, but the most common kidney manifestation asked if at all in hepatitis C, it is mixed cryoglobulinemia. And that marks the end of this entire chapter. It's been quite a lengthy chapter, but you know it's important because I've integrated path micro both.